Ed, welcome to the Clinical Athlete Journal Club number 4. My name is Quinn Hennick, and I'm a proud clinical athlete provider. I'm joined by Kevin McNamara, a recent physical therapy school grad and recent board passeree, clinical athlete forum member, and the one responsible for bringing the Journal Club to life. And he's going to help us facilitate the discussion as always. So, Kevin, thanks for being here, man, and congrats on passing the test.
Yeah, man. Life's looking up.
And yeah,
As
right.
always, happy
It's
to
a
be
big,
here. So,
yeah. And then tell us, you got a residency coming up too.
yeah, that's correct. Yep. So I
Where
start,
at?
yeah, I'm doing a sports residency with Johns Hopkins starting in July. So things are moving along.
You're living your best life right now.
I don't know about that. We'll
We'll
see.
see.
But
Yeah. Well, tonight's Journal Club topic is the role of the core in lower extremity function, and I got core in air quotes. The role of the core in lower extremity function and injury risk. Real quick, I've made a few poll questions to get a feel for the type of crew we have tonight and to set the stage for the discussion. So I'm going to launch the first poll question. It should pop right up in front of you, and it's just your background: clinician, clinician coach trainer, student clinician, student coach. I'll give it like 30 seconds ish. It's been 15, so just cast your vote. So far looking like 67% clinician, which a little different than what we've had before, which is more usually more students. Cool. So about 2/3 clinicians tonight. And then the second question: do you use specific core training in your own regimen? So your own exercise program, your own training program. And again, you might ask, well, what is the core? We'll maybe unpack that as we go through, but just kind of your best reasonable answer as of now. 83% yes. Okay, cool. I would say currently I'm probably in the, I don't think I'm doing anything other than the lifts. Not to say I haven't or won't in the future. It maybe can be something that we talk about as well. Kevin, what about you?
so for me, I think a distinction kind of needs to be made here in terms of what exactly we're trying to accomplish. But in terms of specific core training, I tend to not do anything specific. I think if we're trying to establish some sort of sensory motor competency or kind of teach the person to manage pressures within the thorax or positioning, that's kind of what I would consider like my direct core training. But in terms of not really, no.
Okay. And you bring up some good points we'll probably talk about. And then lastly, do you use specific core training in your client/patient's regimen? So about the same split, 80/20, yes. So I will sometimes prescribe things like hard style front planks with like high tension, short duration, high tension. Sometimes in like non-specific low back pain in the same rationale as isometrics for tendinopathy or something like that, just to get some type of like strong sensory stimulus to see if that can have an analgesic effect, something like that. I'm real careful with how I educate on that though, because I don't want, again, another discussion point probably, but I don't want to give off the notion that I'm saying that they are experiencing pain because their core is weak or that was the cause of their pain. So we talk about that, but and then Kevin, the point that you made from a performance perspective, sometimes I'll give like positional drills to get somebody to just feel what it's like to modulate their trunk stiffness, and then kind of continue to educate that like you modulate that based on the task, based on the intensity of the task, and I find that a lot of times the task itself kind of modulates the required trunk stiffness as is. But any quick thoughts on that?
No, not so much. I think again, it does kind of come back to what we're trying to accomplish, because if it is sort of teaching them positioning or establishing, like we said, that trunk stiffness versus inducing stress or trying to drive performance or adaptation, I think the answer to which one of those we're kind of looking for is going to determine kind of how much I care about and kind of what cues I'll utilize, if any, in terms of core stability. So that's kind of the way that I would look at it.
Yeah, I'm with you there. And lastly, so with those, I think those are good talking points here as we dive into the papers. But lastly, remember our motto in these meetings: they are conducted in the sincere spirit of inquiry after truth, without fondness of dispute or desire of victory. So we want discussion, and we all don't have to agree. Definitely not. Disagreement is healthy in these things, and we can then have healthy discussion about that. But we're not necessarily looking to win one way or another. We're just all trying to be less wrong. So we're all on the same team here. So we'll just have some fun. All right, let's jump right into these papers. You guys should have them there. We got two. One is lead author is Chuter. I hope I'm saying that correctly. And the title is Proximal and Distal Contributions to Lower Extremity Injury, a review of the literature. And the other paper is from Campbell et al. In 2016, and the title there is Abdominal Bracing Increases Ground Reaction Forces and Reduces Knee and Hip Flexion During Landing. So I don't want to talk too long on these two papers, and then I'll throw it to Kevin for some thoughts, and then I throw it to you guys. So I'll talk about the Chuter paper first. It was a review. It was not a systematic review or a meta-analysis. So they kind of, a review of the literature can almost be a glorified blog post, because there's not necessarily a methodological rigor for the review itself is not necessarily there as much as it would be for a systematic review. But it's always good to get a review article in general, just so you have a lot of articles on a particular topic at your disposal, and then you can start to dive into the references. I thought the paper proposed a lot of hypotheticals in regards to foot pronation, which we don't have to talk directly about, because this is about the trunk and the hip, but it was the same with the trunk and the hip. So it was like foot pronation and core stability, and they define core as it relates to osseous and soft tissue structures of the lumbopelvic hip complex. So it's a very general term, and core stability being referring to the ability of the core muscles to stabilize the spine through muscle contraction and maintenance of intra-abdominal pressure. So what does stabilize the spine mean? Usually it means reduction in intersegmental motion or spinal stiffness. And I thought that they cited a lot of hypotheticals, and a lot of the evidence that they cited was retroactive. So, for example, decreased hip abduction strength or decreased lateral trunk flexion strength in patients with patellofemoral pain. So they already have patellofemoral pain, and you're finding these types of things. You can't necessarily make a causal relationship with that. And they kind of get into that, but that's a lot of what they were citing. And I was trying to dig into some of the references that they were using to kind of make the introductory case that core weakness perhaps maybe has a role in lower extremity risk. And as I'm looking at the articles that they cite, a lot of them weren't actually referring to injury, or the article itself in the title, it would say a theoretical construct or a hypothetical concept or something like that. It was like more of a proof of concept paper than it was a particular study. So you kind of got to look at that and see what evidence are they using to cite the proposed mechanisms for these things, because you could just take it at face value, because this article made it sound, like foot pronation and a weak core can really jack you up. So you kind of got to look at those references that they're referring to. They did make one claim, or one of the sentences here was evidence of effective lower limb injury management following core strengthening programs targeting hip muscle strength supports the role of proximal dysfunction in the development of lower limb injury. So it's kind of a claim to that retroactive data. So if we're seeing some type of association between lower limb injury and reduction in core strength compared to those who don't have the injury or pain, or if you put somebody through a hip and core strengthening, then you see improvements in their pain experience, that supports the role of proximal dysfunction or a weak core in the development of these things. And I'm not sure we can make those claims. The big point that had in my head, that kept going in my head as I was reading the Tudor article, was I'm wondering if all this evidence showing an association with trunk weakness in various planes and hip weakness in various planes being associated with those types of pain experiences is just kind of a proxy for somebody who's just less adaptable in general. So I'm wondering if you had tested those people in a myriad of different things, would you have been able to see differences in lots of things, not necessarily a weak hip or a weak core? And I don't know if we have the answer to that. Segueing to, and I'll shut up soon, I promise. Segueing to the Campbell article, I think the Campbell article is maybe a little bit more clear conceptually because it was an actual study, and so they're looking at healthy individuals, so the individual's not currently in pain, not currently injured, looking at a drop jump, and they cued one group to brace their core up to 30% of a max volitional contraction, and they gauged max volitional contraction before the actual study. So they used electrodes on what they're hoping were the internal obliques, and had the people abdominally brace 30% of their max force upon doing a 15-inch drop jump. And they measured ground reaction forces, and they measured trunk, hip, knee, and ankle kinematics or joint angles upon landing. And they compared those to a group of people who did not do any type of abdominal bracing during the drop jump. They just landed like they normally would. And what they found was an increase in ground reaction forces in the group who performed abdominal bracing. So more load was going through the lower extremities. And they found a decrease in hip and knee flexion upon landing in the group that abdominally braced. So just at face value, it seems that if you're consciously bracing a landing, it perhaps in this group, it seems that maybe that took away some of your innate force absorption tactics. It made you a little bit more stiffer and there was a little bit less give. And so those ground reaction forces just kind of went up the chain. Now, I've got a lot of questions about it, and the study itself certainly isn't perfect, so we can get into all that stuff, but I'll stop there and then I'll throw it to Kevin, and then we'll throw it to the rest of the group to see if they had any thoughts, and we can dive deeper.
Yeah, I mean, I share similar sort of thoughts and ideas with this. I think with the Shooter paper, the strongest study that they referenced there to me was the Hewitt paper, talking about abduction angles and ground reaction forces, specifically relating to the ACL, which is kind of interesting considering that the second paper is pretty relevant to that population. So I think one thing where I kind of get hung up is, when we're talking about core stability, like what exactly does that mean? How do we measure that? Like these are all things that I think it's hard to define. And if we don't have a good definition, how do we kind of analyze what's appropriate from what's not, what works from what doesn't? That's my biggest issue with all this stuff, is it's easy to get into the weeds and kind of suck down a rabbit hole if we don't have a good starting definition. And is there a difference between core stability and core strength was another question that I had. I know that they were measuring specifically like anterior and posterior endurance with something like a Sorensen test I looked into, basically holding a position for time. But does that really carry over, and does that matter to any sort of athletic performance? I don't know. So it leaves me with more questions than answers, I think.
There is, on the Sorensen test, yeah, it's just like holding that kind of back extension position level to the ground. I need to look into it, dig into these studies more, but there are some trying to look at that as a prospective risk factor. And I think there was like kind of something there that was probably made out to be a little bit bigger than it was, but the